Yeah, that's like not a small deal. That's like kind of a big deal.
That's a huge increase, right? So Cyrus, let me ask you, would you place a central line in a non-compressible site like a subclavian in somebody with severe thrombocytopenia?
Yeah, I'm gonna take no for 500, Alex. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Cyrus Askin.
And I'm Nick Mark. On this week's episode, we're going to do something a little bit different, our first Critical Care Time Journal Club.
Ooh, I am so excited. We're going to be discussing the recent New England Journal of Medicine article about platelet transfusions prior to central line placement in people with severe thrombocytopenia.
Our goal here is kind of twofold. In each Journal Club episode, we're hoping to talk about our approach to reading the medical literature and why a study does or doesn't change our practice, as well as talking about a particular study.
Absolutely. I think that this is going to be really exciting for us. It's going to be a lot of fun for our listeners. And so just get excited. Let's get to it. So first off, what's your approach to reading a paper like this, Nick?
I do a couple of things, maybe a little bit unconventionally. So first I look at the methods, and then I take a really close look at the figures. Then I go to the supplement, the PDF online, and I kind of see what they're hiding and what the reviewers made them do. And then after I've done that, I go back and I read the results in the discussion. My goal is to sort of not be biased by what they're telling me, but sort of make my own conclusion based on their methods and their results. And I try to look at all their results, including the top secret ones that they didn't want to put in the paper. A couple of things I always look at really closely. So I always try to pay really close attention to who are the people enrolled in the study. And I ask myself, are these people like the people that I take care of in my ICU? I also try to imagine the intervention that they did and think about if I was going to do it or my institution was going to do it, would we do it the way they did it? And one of the key things here is we want to understand applicability, right? Is this study applicable to my patients? And is this intervention applicable to how I would do it? Cyrus, do you have any tricks of the trade for how you approach reading a manuscript like this?
I think I'm probably just going to steal your approach. I mean, that was beautiful. I think so. Mine is far less precise.
Yep.
What I usually do is I just flip to a random page, point to something, and start reading. No, I don't do that. So usually I do read the abstract first. That's what I've kind of grown to do. And the reason I know that may bias me, but at least it's sort of like, it gives me an idea as to like whether I'm actually going to invest the time into reading this, whether it's actually going to be relevant for my practice, and sort of like if right off the bat I can tell this is a study that just affirms something that like we kind of already knew, and maybe there are some other things that I would rather read in the limited time I have, I might move on. But
yeah, I agree with that. I think they say don't judge a book by its cover, but you obviously have to pick what book you're going to read, and the cover tells you that. The abstract tells you, is this a paper that's relevant to me? Should I spend the time to read it? I agree. I try not to be too biased by the abstract, especially since in many cases, especially in journals like NEJM, the authors don't even write the abstract. It's often written by the editors. And so,
right.
That's a good thing and a bad thing, but sometimes I try not to have my interpretation too colored by their conclusion.
Yeah, and I think that's really important. I try to do the same thing. I think, then once I've sort of done that, then I'll usually move to the methods section, and then get an idea as to what they actually did, what their research population, was, who was excluded, all that good stuff, and then the results, and then I'll. At that point, I find the discussion to be kind of interesting as well, kind of see what their take on the research was. Notice I didn't mention the introduction. A lot of times at that point, I don't really necessarily need to go back and read the introduction unless there's something I really need to go searching for. And then if I'm really interested, then I'll kind of go after the supplemental articles or supplemental, like the appendices, or if they reference one and I'm like, that's interesting. That they referenced it but didn't include it, then I'll often go back and look. That's usually my approach. Like I said, it's not quite as
cynical as mine.
I was going to say professional as yours, but cynical works too.
Great. Okay. Well, do you want to summarize the paper and kind of tell us what it's about?
Absolutely. So this paper is, like we said, is published in NEJM. It's a randomized controlled trial from the Netherlands titled Platelet Transfusion before CVC Placement in Patients with Thrombocytopenia. It's a very recent article. It was published in May of 2023. So again, being a multi-center trial, there were 10 hospitals that were involved in this study. And all the hospitals looked at both ICU patients and hem-onc patients. At least that's best I could tell. And to be eligible for this study, you had to have a platelet count of between 10 and 50,000 platelets per cubic millimeter. They did exclude patients with coagulopathies or those on anticoagulants. Initially, they required patients to have an INR of less than 1.5, but then they sort of amended the research protocol to allow an INR of up to 3. So with that, they randomized patients 1-to-1 either to receive a unit of platelets or nothing prior to central venous catheter placement. The study was not blinded, so that's something important to note. And in this study, an experienced, quote unquote, experienced operator was utilized to place the ultrasound guided central venous catheter within about an hour of randomization. And I have a feeling we'll talk about, how they define experienced, but they use that term experienced, for the operator. And then kind of, finishing things off as far as the basic, rundown. Randomization was stratified by trial center and by catheter type. They did look at HG line versus regular catheter. They did not stratify where the line was placed, whether it was an IJ, a subclavian, or a femoral vein, although they did provide some forest plot data that does cover that in their subgroup.
We are going to stratify later, I suspect.
Yes, I think we will. And then probably the other important point is this is a non-inferiority trial. So they were testing the hypothesis that not giving platelets was non-inferior to giving platelets. This was not, they were not looking for superiority.
That many negatives is not at all unclear, by the way.
Yes, it's not at all not unclear.
Right. So I'm going to summarize in my own words that basically they tested whether withholding platelets before a central line was no worse than giving platelets before a central line. And what was their primary outcome? This is important as well.
Yeah, so their primary outcome was the occurrence of catheter-related bleeding, specifically what they defined as grade 2 or higher.
And what is grade 2 or higher catheter-related bleeding?
Yeah, so and I read that and I was like, what the heck is this? Because I don't usually think of bleeding in terms of grades like that. But they do provide a nice little table that discusses what they mean by grades of bleeding in regards to CVC placement. So grade 1 would be that the bleeding stopped with minimal interventions, such as holding pressure for less than 20 minutes. Grade 2 would be more than 20 minutes required before the bleeding would stop with pressure applied. And then grade 3 would be additional surgical or IR interventions to stop the bleeding in the absence of hemodynamic instability. And finally, grade 4 would be sort of those advanced interventions with hemodynamic instability. So like basically low-key hemorrhagic shock.
Exactly. Right. And so I think we could agree that grade 2 or higher, and particularly grade 3 or higher, is a very significant complication. So I think that's a good endpoint for the trial.
Yeah, I would agree with that.
What did they find?
Yeah, so in this study, they looked at 373 episodes of central venous catheter placement, involving a total of 338 patients. So there were some twosies there, presumably. And then we had basically grade 2 to grade 4 occurrence. Grade 2 to grade 4 bleeding occurred in 9 out of 188 patients, or just shy of 5% in the transfusion group, but occurred in 22 out of 185 patients, just shy of 12% in the non-transfused group, which conveys a relative risk of 2.45, which was in fact significant. They then go on to say that serious bleeding events occurred in 4 out of 188 of the patients that received platelet transfusions and 9 of those that did not. So that was 4 out of 188 and 9 out of 185, which was, of course, that's a higher number, but there wasn't significance achieved. And so
and I think so right off the bat, we can see that there was basically double the rate of grade 2 or higher bleeding and double the rate of grade 3 or higher bleeding. So there was a lot more bleeding in the no platelet. What did the authors conclude based on that?
Yeah, so essentially the authors came to the conclusion that withholding platelets did not meet the predefined margin for non-inferiority.
So it was
whatever that
was
means.
not worse.
It was not worse. Correct.
It was not worse.
Yeah,
so
right.
Case closed? You done here?
Yeah, I mean, I think that's pretty much it for the episode. We're done in about 13 minutes.
Yeah, not so fast. So I think we need to double click on a couple of these details. And I think if we look at table 1, we can see a couple of important things. So first of all, most of the patients were hem-onc patients. And second, they were doing a lot of subclavian lines. And if we look at figure 2, they have a subgroup analysis, and we can see that basically all of the increased bleeding risk was driven by lines placed on the hematology ward and subclavian lines. And specifically, if we look at that figure 2, we can see that there was no difference in bleeding risk with and without platelets for IJ lines, but there was a 6-fold increased risk for bleeding with subclavian lines when they were placed without platelet transfusion.
Yeah, that's like not a small deal. That's like kind of a big deal.
That's a huge increase, right? So Cyrus, let me ask you, would you place a central line in a non-compressible site like a subclavian in somebody with severe thrombocytopenia?
Yeah, I'm gonna take no for 500, Alex.
Right. I don't think most of us would, right? I think the idea that you're going to do a risky procedure in somebody who's coagulopathic in a place where you can't easily address a common complication of that procedure is a little nuts. And so I think like this is a really good example of a study where they probably should have stratified by the site of line placement, because their data is actually showing me that the practice of doing a invasive procedure at a non-compressible site is risky, which is something that I already knew.
Right. And that's
it's not really telling me anything about platelets.
Right. Yeah, that's one of the issues I sort of take with this study is it's sort of like what I was talking about earlier with sort of like reviewing abstracts and trying to figure out, is this something I kind of already knew? Well, sure. Like if you already take probably the riskiest of the sort of 3 places where we typically put catheters, central lines in, and then you make it a little riskier with thrombocytopenia, is that in fact riskier? Well, yes, it is by definition. And so we probably shouldn't be doing it, full stop, end of story. So yeah, I mean, that's, unless you absolutely have to, it's something that I would certainly avoid, at all costs, if there were any other alternatives.
But I do think one thing the paper tells us is that if you are going to place a subclavian line in somebody who's thrombocytopenic, you absolutely should give them platelets before or while you're doing it. So I think that element of the paper really rings true.
I would agree.
And that's something that I think many of us have learned with experience, by the way, that if you do a procedure and the person starts bleeding, give them platelets. Speaking of experience.
Yeah. So it's funny. Experience is such an interesting word when used in medicine. How do you define it? What is experience? Is it total number of reps? Is it number of reps per unit time? Is it number of reps in different environments? I mean, I think, Nick, you and I both agree that it's a very difficult thing to define. In the paper, they talk about...
It's actually very easy to define. Experience is defined as one fewer than the number that I've done, right?
Oh, that's right.
That's the way everyone likes to define experience, right?
I'm surprised they didn't put that in the paper, actually.
Right. So in the paper, they said that an operator who had performed 50 central lines was experienced.
Right.
And,
right.
You could look at this 2 ways. Like, I think like, a first or second year resident who's done 50 lines, I would say they are experienced. Somebody who, has been doing lines for years and has done 50 total over, let's say, a decade, that doesn't seem that experienced. That seems like, doing 5 lines a year might just be barely sufficient for skills maintenance. So I think, this is a little problematic, right? There's a big difference between somebody who is like a proceduralist, who's frequently doing lines, who's doing, 100 plus a year, and somebody who's done 50 over a career where they may sort of be at a stage where their skills are adequate, but they're not expert. And I think like defining it experienced as greater than 50 is a little problematic because, you don't really know what that is. That could be like, an experienced resident, or that could be a, person who very infrequently does lines, many years since they did their last line. And those are wildly different situations.
Absolutely. I mean, I couldn't agree more, Nick. I think you hit the nail on the head. Now, sort of in the same vein as discussing experience in terms of numbers, might be a good opportunity for our listeners to talk about maybe some of the tips and tricks that we use when it comes to placing lines, tips and tricks that maybe come with experience. For me, a couple of the things I like to do. So when it comes to dilator technique, of course, you need to dilate the soft tissue in order to actually, place your line. And I'm having bent many a wire as a young resident and as an early fellow. I've learned the importance of kind of using riding your dilator along the axis of the wire, being very cautious to sort of floss your wire. You move your wire in and out of plane with the dilator as you're making sure that you're not actually applying sort of perpendicular force to the wire. And then I sort of use this like in and out corkscrewing motion to sort of like enter the tissue, liberate some of the tissue distally, and then I kind of come back a little bit and re-enter. And I find that sort of minimizes how I'm traumatizing the area and kind of gives me a better end result.
I think especially if you place larger lines, it's very important to have safe dilator technique. I think that people tend to think that the complications happen with the needle. And you can cause a pneumothorax with a needle, but actually the dilator is very dangerous, and people tend to underestimate the risks of the dilator. And the mistakes that people make, like you listed a bunch of them there. So one is they push it in not along the wire, so that it basically just dissects through tissue. Another is they back wall the vessel. So they dilate through the tissue into the vessel and then out the bottom of the vessel, which can cause significant hemorrhage. And then sometimes people will even like hub the dilator. So like they'll put the dilator in along the wire, it'll go down into the vessel, and then it will go down the vessel. And then if it happens to hit a branch in the vessel, it can cause significant vascular trauma deep. And that's really bad because that's something that you might not be able to notice initially. And that might be something that's not compressible. So that's kind of you creating a vascular surgery emergency by bad dilator technique. So yeah, I completely agree that like one of the things that goes into safely doing lines is not harming people with a dilator. Here's another thing we've talked about. So when you place hemodialysis lines, they come with 2 dilators typically. Do you use one or both? And people differ on this.
So my preference in most cases is to just use one.
Mine too.
Because I find that I'm able to get a snugger fit when I ultimately advance the like the dialysis or the trialysis line. And it's also, again, I'm traumatizing the tissue less. And so
I agree.
I find that better.
I only use the second dilator if I literally can't pass the catheter after one, and I've never had that happen. I have one colleague who she doesn't even use the dilator. She just like very carefully and methodically advances the catheter over the wire with no dilator. And
the big Nick,
and that works for her apparently.
Yeah. You have to. I imagine you have to make a pretty sizable nick in order to do that. But
you do, yeah. You can't get through the skin like that, but I think you can, push through soft tissue, especially with a larger catheter like a dialysis line. That's not my preferred way to do it. I think a single dilation is key, but I think people tend to be overly generous with both the depth of dilation and sometimes with dilating twice, and that creates a large track around the catheter that can cause continued bleeding.
Yeah, absolutely.
Next, we should probably talk about kind of the opposite approach, which is to make a really small hole, to use a micropuncture kit. So do you like those in your shop?
I do. So really quickly, one thing that I wanted to mention before we talk about the micropuncture is just, in keeping with your colleague and her skin nicks, that nick is also an important part too. And I think all of this is probably content we can cover maybe in a future video episode where we talk about, access techniques and whatnot. But the one thing I'll say for the audience is, being careful to sort of like make your incision as close to the wire as possible along the wire, so that you're not, creating significant skin bridges, i.e. skin in between incision and wire. that are really going to defeat the purpose of what you're doing in the first place. And so I'm very careful with that. And then what I'll also do is sort of wiggle the wire around. If there are little skin bridges, I can often sort of break those apart with the wire itself, along with my dilation. I don't know if that's something you do, Nick.
Yeah, no, I like that. And I also like the approach of sometimes you need access, you need visualization. So you have to make a larger skin nick sometimes, but you can suture that closed. Like one of the best things you can do to control bleeding is to proactively do like a purse string around, or just a single stitch next to your catheter to close that skin nick. And that will often stop a lot of bleeding. And it's way better to do that, by the way, when you're sterile placing the procedure than like an hour later when it's continuing to ooze and come back and try to get everything clean again. So proactive control is a big thing.
Yeah.
Let's
so
talk about micropuncture.
I agree. Yeah. So getting back to kind of your initial question, I like the micropuncture kits quite a bit. I use them often for arterial access, and then I use them less frequently, but I do use them for venous access as well. I like the fact that it's a smaller needle. I feel like I have better control of the needle. Overall, I do find that you get sort of a better result, probably on aggregate when you use them. Nick, I take it you use those?
Sometimes, yeah. I think I did a lot of PA catheters in the cath lab, and they exclusively use micropuncture for that. And it really kind of sold me on why this is a useful, safer way to do it. I mean, there's some literature to support that too. There are some studies that show lower rates of bleeding, hematoma, et cetera. It's one more thing to do. It's not something that I think you need to do for everybody, but I think if you're anticipating a coagulopathic person or a challenging placement, micropuncture is a great thing to reach for, to try to reduce that risk. It's much better to make a 21 gauge hole in a vessel than an 18 gauge hole in a vessel. And if you have trouble, like for example, like getting the wire in, then you've only made a 21 gauge hole, not an 18 gauge hole.
Right. I think that's awesome, Nick. I think that's all. Yeah, I think that's a good way to sort of encapsulate that. Now, do you do for these subclavians? Obviously that's maybe a little bit of a higher risk line. Do you use ultrasound for those?
I usually don't. So one of my favorite things about the subclavian is that you can do it without ultrasound. I do sometimes do them with. I think technically it is more complicated to do an ultrasound guided subclavian, and so I think it's definitely a safe and maybe safer way to do the procedure. But I think for me, it defeats some of the advantages of the procedure. Part of the advantages, one of the things that I like so much about subclavians is you can do them, quickly and safely without ultrasound.
Yeah. And I tend to feel the same way. I like it in theory, but in practice, I find it more cumbersome. And I often ask myself, well, if I'm doing this, why wouldn't I do the procedure that I've done kind of many more times, which would be, a right IJ or a left IJ if need be or whatever. Sometimes there are reasons why you can't. I totally recognize that. And certainly like the subclavian lines are there, when you get one in, within 10 seconds of starting the procedure, you pat yourself on the back, you feel good about it. You're able to, suture that in very securely. You're able to dress it, I think, very securely as well. And then I think patients in general are more comfortable and very importantly too, the nurses tend to have an easier time caring for those lines.
Yeah, it's definitely a more comfortable line to have. It has less implications for mobility. I totally agree with that. I guess one other thing we should talk about real quick is holding pressure. So let's say that you've done a line and there's bleeding. I think one mistake that people often make is they don't hold pressure right away. And I think holding pressure for just a minute or two right away is often all it takes. And sometimes if you wait, that then it actually takes longer for the bleeding to stop. The other thing is that I think people tend to make some technique errors when they hold pressure. So like if you just push with like one or two fingers, you can exert a lot of pressure and you can do excellent hemostasis like that. If you take like a boat of gauze and you put that down, you try to push through that boat of gauze, you're now applying pressure much more diffusely and much less effectively. You can actually do the math on this. It's kind of a fun exercise. If you think about the area on the bottom of the wheels of an 18-wheeler truck and the weight of the truck is actually applying less pressure per square centimeter to the road than you can if you push hard with your fingers. Like your fingers are an amazing tool to apply pressure to achieve hemostasis. So use them wisely. If you put in a line and there's bleeding, push hard, give it a minute or two, be patient. And often that's all it takes to stop it.
Man, well, given that I cannot trump or otherwise outdo that tidbit of knowledge, maybe I'll try to bring things back to this paper, and perhaps it's a good time to talk about who was not in the study. And so, again, getting back to this paper, our ICU populations, we have a lot of folks that have cirrhosis or folks that are uremic, and so really the number of people with those conditions is quite low. And we know that those folks are,
which is a major limitation of the study, I would say.
Right. Absolutely. Yeah, absolutely. What other sort of thoughts do you have in regards to these groups and their bleeding risk?
Yeah, I think there's a couple of things that maybe you do a little differently in these groups. It's not uncommon to see somebody who has renal failure, uremia, and they're high risk of bleeding, right? And especially when you have somebody who's got both cirrhosis and renal failure, they've got a lot of reasons to be coagulopathic potentially. And this is a situation where I often do two things. I'll often give DDAVP, and the idea here is that the platelets that they do have are often inactivated by uremia, and DDAVP causes granules in the platelets to externalize more of the glycoprotein to the surface of the platelet. So the platelets that are already in the person will work better, at least transiently. And then I'll give them a platelet transfusion while I'm doing the line. And I think the combination of DDAVP just before and platelets during substantially reduces bleeding.
Are you referring to the Weibel bodies or whatever they're called?
Yes. Good old Weibel.
I feel like I remember those from I don't know why these random tidbits of relatively useless medical trivia stay in my brain. But I feel like I remember that from when I was in pathology or something.
Medicine has got so many eponyms. Sometimes you feel like you're Harry Potter or something if you get to use them.
Yeah, no, it's I need anything that's going to bolster my my sense of self-worth. I'll take it. We've talked about this paper. I think we've done a pretty good job chatting about the context, but I'm curious, Nick, what are your feelings on this paper? So let's get a little touchy-feely.
Yeah, so there's an old joke about journal clubs that they only have two interpretations. One, I knew that already, and two, I don't believe it. This is actually the rare paper where I think I can take both of those, one and two. I already knew that you should not do subclavian lines in people with severe thrombocytopenia, and I don't believe the conclusion that an experienced operator needs to transfuse platelets prior to placing an ultrasound-guided IJ. I think that there are other techniques like we've talked about that can make an ultrasound-guided IJ safe, and I think the paper actually supports that because the risk of bleeding with and without platelets was the same for IJs. So I think the paper confirms my practice already, which is not to do something risky and that it is possible to do something safely, namely an ultrasound-guided IJ.
So what you're saying is really this doesn't change your practice.
It does not, no. And I think it's important to point out that this is a good study. This is a methodologically rigorous study. It was done well. And I don't have any flaws in the way they did the study, except possibly would have been better if they'd stratified by line placement site. I suspect there were reasons why they couldn't do that, because maybe the operator didn't know until they went to do the procedure where they were going to do the line. So it might not have just been technically feasible to do it that way. But I think the real take-home point here for our listeners who are interested in how to critically appraise a study is you always have to think about applicability. Are the patients in this study like the patients that I take care of? And do the people in this study perform an intervention the same way I would? And I think in this case, the population is somewhat different than who I see in my ICU, but the way they do the procedure is extremely different. I just would not do subclavians in high-risk thrombocytopenic patients where I couldn't compress the site. Cyrus, do you want to get in a last word on von Baarle et al.?
I think I would. So I totally agree. This is a rigorous study. I thought it was pretty well executed. I appreciated in particular their sort of subgroup analysis in the forest plot that they included on, I believe it's figure 2. And I'll also say, I'll also plug like the New England Journal of Medicine has, in the last few years, they've really upped their game in terms of their video summaries of articles, which obviously doesn't give you everything that you need, but I think those are like great 3-ish minute ways of reviewing the article and getting some really useful information. But getting back to the article itself, I think that it really does illustrate an important point when it comes to our review of the literature and evidence-based medicine in general. And that is that it can often be tempting to sort of over extrapolate findings. And what I mean by that is we really should be comparing apples to apples and oranges to oranges. Even in cases where it may be convenient to use the data from one study and apply it to your population or to your patient, really, if there's significant discrepancy between the two groups, that practice is really not just ill-advised, but it could result in a poor outcome for your patient.
Perfect.
We hope you enjoyed our first Journal Club episode as much as we enjoyed putting it together. If you agree or disagree with us, please let us know by tweeting us at NickMark or at Askins_Razor or via our podcast Twitter at Critical Care Time. Don't forget to follow us on Instagram, critical_care_time, and check out our Critical Care Time YouTube channel.
As we all know, Twitter is an excellent place to disagree with one another. If you prefer a slightly calmer, or maybe just you want to shout at us with more than 240 characters, you can go to our website and you can leave us a comment there. That's www.criticalcaretime.com.
Excellent. And please, if you have time, be sure to give us a like, leave us a 5-star rating on iTunes or your favorite podcast app.
And if you have suggestions for articles for future journal clubs, we'd love to hear them. It doesn't have to be a recent article. We're happy to go back and bash old articles too. We're not selective.
Yes, we're equal opportunity offenders in that regard. So, and of course, before we go, we'd like to thank all the incredible members of our podcast staff for helping to make this show possible. We'd also like to thank our production team over at Podpace. And last but certainly not least for thank yous, Kurt Belknap for our awesome theme music. Additionally, we are fortunate in that this episode and all episodes in season 1 of Critical Care Time is sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, www.cstarmedical.com, to learn more.
And just a reminder, this podcast and all the related media, including but not limited to the animations, graphics, videos, are the property of Critical Care Time. We would love for you to enjoy and share our content, and you're free to do so. We just ask that you cite the source. The views expressed within this podcast and any associated media do not reflect the views of our employers or any of the staff members, friends, or guests of the show. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarity to real-world cases are purely coincidence. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. Thanks for listening, everybody. See you soon.
Thank you, guys. Until next time.